Welcome to what we like to refer to as TR squared, Tricuspid Regurgitation Therapy Retreat. So this afternoon is all about TR, which I think is just a lot of fun. And I'm joined here by my co-moderator, Dr. Gorav Ailawadi, Nadira Hamid, Molly Szerlip. Is that Firas? Yeah, it's Firas. And Dr. Omar Khalique. So welcome. And we'll go and kick it off here. I think Nadira, you're first. Novel quantitation of TR. How do we measure?
Thank you. Right, thank you so much, Paul and CVI, for the invitation. And today I'll be talking to you about novel TR quantitative techniques. How do I move the slides? Oh, yeah. Hold on. No, there's no keyboard. How do I move forward? Oh, there you go. Oh, wait. Go back. Yeah. Oh, I didn't do that. Okay, so I have no disclosures. So this is my first slide. And I think we all know the new TR grading scheme. I mean, we don't just look at the TR jet and just assessing it. I'm not sure why the videos are not playing, but certainly we all now know from all the literature and all the trials that certainly grading TR is beyond severe to massive and torrential. And this really stems from the SCOUT trial a couple of years ago by Dr. Han, and really showed that reduction of TR by just one grade really make patients feel better. They improve the stroke volume, the quality of life, and really quantitative TR from, besides severe and to massive or torrential has been related to survival. And this is seen in the TTVR registry that really has shown that, grading TR's severity really helps to predict the clinical outcomes after you actually intervene on the tricuspid using the transcatheter devices. And so there's a need to define these parameters to really predict procedural success. So quantitating it, I think from the ASC guidelines in 2017 really, you can see this table, it's really busy, but certainly really predominantly by PISA quantitative assessment, and that's not enough. So in our lab, in the core lab 2, we quantifying using new parameters. The top left-hand side, we do an average of a vena contractor from your orthogonal views from inflow and four-chamber, as we know the TR jet is not circular. Bottom left, we quantify using 2D quantitative, measuring the stroke volume across the tricuspid valve annulus and diastolic volume, and then subtracting it to your forward stroke volume in the absence of regurgitation. We do a lot of 3D, even with transthoracic on the right-hand side, measuring that 3D vena contractor area and getting truly the grading of your TR. Pitfalls, if you just measure just a single view on the vena contractor is insufficient. That's why we use both the inflow and the four-chamber view to get the elliptical TR jet. PISA, we all know that, assuming it is limitations because the TR jet, you can see on the top right-hand side using the 3D, it's not a circular orifice, it's not a hemisphere proximal convergence, and using a single time point for measurement really underestimate TR severity using PISA quantitation. So here using a couple of papers by Winkle and Dr. Han as well shows that integrated PISA assessment during the systolic cycle actually really quantify the TR severity. And what we do in our lab is usually measuring the PISA radius across the systolic cycle. It's a lot of work, but certainly quantifies the TR severity into massive or torrential as much as equivalent to your 3D. More recently, an article a couple of weeks ago shows that PISA correction by Tomaselli in the European group shows that correcting the PISA actually quantifies the TR as close to your 2D and 3D quantitative measures. And it has shown as well in patients with massive or torrential TR with a tenting height and tenting area and leaflet angle, as you can see in the parameters in the screen, by PISA correction actually is much more equivalent to your 2D and 3D quantitation. So PISA correction may be the way forward. It's a lot of work, but I think with practice in our busy clinical lab, it may be helpful. 3D vena contractor area as shown. This is a case that we did in a pre-clip with torrential TR on the right-hand side, and post-tri clip with a transthoracic, I was able to measure the 3D vena contractor average of 41 millimeters square and regurgitant volume of 26 cc, so from a torrential all the way down to mild to moderate TR. So here in the new established TR quantitation that was just published a couple of months ago, really highlighting the key parameters besides venocontractor width, 2D EROA, regurgitant volume and fraction as equivalent with cardiac MRI, and 3D venocontractor down to not only severe, moderate to severe, massive, and torrential. So the novel key parameters for TR, the pearls and pitfall, we do need to go beyond severe, measuring venocontractor in 2 orthogonal views, using as much as 3D venocontractor area. And PISA, we do know the limitations, and now with the article a couple of weeks ago published by the European group with an angle correction can get us to quantify TR as close as, accurate as possible. What are the new features as well besides quantifying TR? Here we know etiologies of TR, we define it as primary and secondary, but the novel quantification, we should be quantifying and classifying TR not only into the atrial and ventricular functional TR, but those TR that is associated with lead has a group on its own as well, and that's the new classification that we should be adapting to in our patients as well. Now, besides classifying, quantifying, we cannot forget the right heart morphology. So we need to also as much quantify the right ventricle from echo, as I know Omar Khalique will talk to you about RV function from other modalities, but echo does has its limitation, and I can admit that. But we do have new parameters like 3D RV volumes, RV global longitudinal strain that we do need to adapt in our clinical practice to as much to quantify the right ventricular function. The new kid on the block, as I mentioned in my previous presentations, is the RV-PA coupling. It's essentially measuring the RV contractility against the RV afterload. So it's a ratio of your free wall strain, global longitudinal strain, fractional area strain, or TAPC to your RV SP. And he has shown in multiple literature in the tricuspid group by Fortuny in Europe, it's related to mortality in the cutoff of 0.35. In the group of the Transcatheter registry, my colleague Michael Brenner has shown that it's related to mortality in TR, and the cutoff for this is 0.4. As we are going into the pivotal trials, we will certainly have a much better idea of the RVPA coupling in this group. And I cannot stand here and say that echo obviously is the way, but we do need to admit using other modalities, and that is the novel approach to tricuspid imaging, using CT and cardiac MRI, really to identify these patients besides quantifying TR from echo. Here's a slide from my colleague as well, Dr. Joao Cavalcante, who's doing the imaging sub-study, and this is how we're going to quantify as much TR as possible using other modalities like cardiac MRI and CT post-TriClip. And we're excited to see the results of this. So the tricuspid valve, as you know, is an unforgettable valve. It's a never forget me valve. The key is not only diagnosing, quantifying TR so that we can select these patients and identify which patients is suitable for the transcatheter device, identifying and really selecting these patients based on the right heart morphology and function, and using all imaging modalities, CT, MRI, ICE, and the new technology with Fusion AI. Thank you very much.
So thank you, Nadira. Really outstanding overview. Obviously, there's a lot of information in that for all of us to digest. One of the things that we've been frustrated by is just the variability of even screening for TR. Both screening from symptoms as well as screening on echo. Many patients we see, that their screening surface echoes don't have significant TR. They may or may not be symptomatic, and of course, their transesophageal echo shows, torrential TR. Anything coming down the pike to help with that? Because that's been, at least for many centers, a source of frustration when we're thinking about enrollment in trials.
Thank you very much. That's a great question. In the screening process, I can understand the different sites with the frustration that we only diagnose TR based on transthoracic. And the real reason for that is to make sure that the follow-up of these patients, that we can really identify the severity of TR. Transthoracic it has its limitations for some individuals, and I think that's how we underestimate TR in this population, and then they get treated really late. So I think, the threshold, if there is suspicion based on the symptoms and the TR and other, right heart cath numbers, really you suspect, I think the threshold to do TE should be low.
I have a really simple question for Nadira. So Nadira, the novel echo parameters, if we use them instead of color, how many more patients are going to be identified as having severe?
I think there will be a lot. Based on the color alone, I've seen, if you just look at it and if you quantify it, I actually get torrential TR. Because your RA can be so huge and you don't see the flow of the TR all the way, swirling like you see in the mitral regurgitation jet. And so if you look as an imager, just look at the jet, you think, oh, it's just moderate. But actually, I'm so used to seeing so many and I'm like, I know it's torrential and I prove it by doing quantification. So I think imagers, we do have to do it, and I know it's a busy lab. So that's why, like with PISA, I think, the threshold to do it, I think should make it much smoother.
So another one point you brought up is that even in early annuloplasty trials, an improvement in survival with just decreasing from torrential to severe. One question I have is, with a lot of these patients, are not that symptomatic. Even until they get to very, very significant TR. Do you foresee that there's a survival benefit even in those patients that don't have symptoms? Molly's shaking her head, so I'm curious what the panel thinks about that.
Well, that's the question, right? If we treat it early enough. And when she was talking, I was just thinking about that I think that there's a sweet spot. You can't treat all, mild TR, but there's some sweet spot that we haven't really figured out yet where that transition from moderate TR or mild to moderate, where it really starts affecting the hemodynamics and the RV, and maybe it's doing cardiac MRI on anybody, as a screening tool on anybody with TR, and then following the RV parameters or the RV dimension or something. I don't know, I'm just making that up. But I will tell you, if you have TR and you have, like, say, for instance, a pacemaker lead, and you have mild or moderate TR, then I think that is going to eventually be bad, because you're holding the leaflets open, and so it's got to end up being bad. I don't know.
Also, if I want to comment, it's a as an interventional cardiologist, I look at the echo, and when it's TR square, like massive torrential, I pick it up right away. There's no question. When it's moderate and maybe moderate to severe, or maybe severe, this is where it becomes very difficult to tell with certainty. Is it moderate to severe, or is it severe, or is it moderate? And I always ask the question: Is it dynamic? Most TR are functional. Is it dynamic? So could it be like you will be moderate on Monday morning and severe on Friday afternoon after a few drinks and some pizza? And the question is, how should we approach those patients? Medical therapy, I guess, we'll see what it shows in the trial. But to our belief, medical therapy will have little impact on that.
I would say that we need more dynamic valve testing. We just don't do enough of it. And it's silly to think that what we see at rest is what happens during exercise. Omar, you had a comment?
Yeah, I was going to make a similar point. I think just like we have for AS and MR, right, patients with equivocal symptoms and maybe equivocal quantitation, right, they go on the treadmill or wherever it is, and we look at it before and after, both RV function and regurgitation. So I think that's a direction we need to head in, and I think that will clarify some of these issues.
All right, great. Great discussion. We're going to continue on with the session. Next, Dharam Kumbhani is going to talk about aspirations for transcatheter TR therapy.
Thanks so much. Thanks.
Okay, so hey, good afternoon, everyone. Thank you so much for the invitation. So yeah, I'm going to be talking about the aspirations for transcatheter PR therapy, and I don't have any industry disclosures to discuss. So, the landscape for transcatheter interventions has obviously changed dramatically. We've had great success by way of TAVR for aortic interventions, and we've certainly made a lot of strides for mitral interventions over the last decade or so, although there are still several obstacles that we have to overcome. But really the hardest obstacle of all and the tallest peak for us to climb is going to be tricuspid. And there are several challenges in this domain, and some of these I'm going to try to discuss in the next few minutes. So when you think about transcatheter TR therapy, what do we aspire to achieve? So first is we want to achieve a surgery-like result. So we want great efficacy, and we want to do that with equal or better safety as compared with surgery. We also obviously want patients to feel better, and then like all other therapies, we are interested in the long-term performance of these therapies, and also the feasibility of reintervention, as well as the ability to cohabitate with other interventions that they may need, such as pacemakers, etc. Now, this field is still in its infancy, and so the last two aspects, I think, time will tell. But I'm going to focus my next few slides on sort of understanding what are the obstacles for the first three things that I discussed. So first is, we all know this, but tricuspid valve is a complicated valve. The leaflets are thin, so as we all know, there are three leaflets, septal, anterior, posterior. But that's not the norm. There are many exceptions. It may be bicuspid, it may be quadricuspid. The posterior leaflet in particular can have multiple scallops, and these leaflets are very thin, so imaging is very challenging. And these leaflets, because they are thin, are not ideal for some of the edge-to-edge repair technologies, and SLDA is much more common with tricuspid interventions than it is with mitral interventions. And for the same reason, maneuvering devices in these leaflets can also be challenging. The second, what was just being discussed, the annulus is not linear. It's also D-shaped. There's a straighter, sort of more fibrotic septal side and a more rounded lateral and posterior side. Also, by calling it an annulus, it sort of implies a distinct fibrous structure, but that may be a misnomer based on some of the cadaveric dissection studies. And so this is really important for the stability of a lot of the annular anchoring systems, as this can vary along the circumference of the annulus. We also just talked about the dynamic changes in the annulus during different stages of the cardiac cycle, and I think that's very important for device design. And frequently, when you have annular dilatation, you need very large devices. The other thing is, TR is multifactorial. Now, this is not dissimilar from what we've seen on the mitral side, but there are many different anatomic issues that arise when patients have tricuspid regurg. So one of the biggest problems we just talked about was annular dilatation, but also the tricuspid valve is more apical and more anterior than the other valves, and so there is significant tethering and tenting of the leaflets. Again, this was sort of mentioned in the last talk. The septal leaflet in particular is particularly prone to this. It can be pretty retracted and can be very hard to grasp with some of the edge-to-edge repair technologies. In addition, there's displacement of the papillary muscles, and the chordae can get stretched, and this can result in interaction with many of the devices that are used in this space. The adjacent structures also play a very important role, and so, the right atrium is typically a small cavity, and even when it's dilated, maneuvering these devices in that space can be challenging. The access predominantly to the tricuspid valve is via the SVC or the IVC, and again, the SVC size can limit that. The SVC is also not perfectly linear, so that can also be a challenge for some of the technologies, and then similarly for the IVC, the diameter is important. In addition, there are a number of important structures in close proximity to the tricuspid valve, including the coronary sinus, the right coronary artery, and the non-coronary cusp of the aortic valve, and there can be an interaction and impingement of these structures, with various devices. An important one to remember is, of course, the triangle of Koch, which is formed by the reflection of the septal leaflet, the tendon of Todaro, and the coronary sinus. And at the apex of that lies the AV node, which is shown as a star over there, and that sort of continues towards the medial papillary muscle and beyond as a right bundle. And so these devices come very close to that, resulting in frequent heart block. And then also the membranous septum, which is particularly thin, is also right next to that, and there's a risk of perforation and VSTs with some of the larger devices. We have a whole talk dedicated to this, so I'm just going to mention that RV function is challenging to assess, And typically with tricuspid regurg, you have significant RV dilatation and hypertrophy, but there are many ways in which you can quantify RV contractile dysfunction, such as TAPC, S prime, fractional area change, etc. There's also measures for RV diastolic dysfunction, volumetric assessments, etc. Again, there's a whole talk that I'm looking forward to as well. But this is an important part of why we are, struggle with tricuspid interventions. Also was discussed, the optimal timing of these tricuspid interventions is unclear. So, it is pretty clear that the severity of tricuspid regurg has an effect on long-term outcomes in these patients. And the exact etiology of tricuspid regurg is not necessarily important. So whether that's lead-related TR, TR post-TAVR, or isolated TR, having more severe TR lends itself to worse prognosis. So what is unclear, what Molly was also just saying, is there a sweet spot where intervening earlier would be helpful? Do we wait till patients have symptoms or RV dysfunction or some signs of liver congestion? And on the other side, are there certain patients that are too far gone where tricuspid interventions may not be beneficial, such as patients with cirrhosis, severe pulmonary hypertension, or severe RV dysfunction? So it's a challenging field, and we're still kind of scratching the surface on this. And then the next point is, is residual TR a problem? So, these are two patients. I don't know if there's a way to get the movies to play, but these are two patients that we saw in Valve Clinic. On the left-hand side, you had a patient with severe TR that had an isolated tricuspid valve repair. And on the right-hand side, you have a patient who was high, prohibitive risk and ended up with edge-to-edge repair and had sort of, mild to moderate residual TR. And so symptomatically, they both felt a lot better. But the question is one of them going to do worse than the other in the long run? And so these are some of the things we still have to, figure out as we go forward. And I'll end with this. I think, Cliff Kavinsky had this really nice perspective piece in Circulation this year, that prevention may be better than cure. So a lot of TR is related to leads, and he's proposed this sort of very thoughtful approach where patients who may be at high risk for having lead-related TR, perhaps there is a role for imaging guidance in these patients. And so you're looking for leaflet impingement, you're looking for new TR, and you would maybe select out patients that need bigger leads, such as ICD leads or multiple leads, or have baseline RV dysfunction. So this is something which, as a field, we'll also have to understand sort of what is the best practice to avoid lead-related TR. So that's what I have. Thank you so much for your time.
Fantastic, Dharam. Thank you so much. Okay, so we're a little short on time, but I need to ask the panel. I'm going to start at the end here. Omar, do we need to get rid of all the TR? And I'm going to ask a yes or no, going from Omar right to left.
Yes.
Maybe. No, I just did that.
That's a yes.
Nadira?
I would say we need both, yeah, in some,
So
certain
conditional?
I
The
think
surgeon.
everybody's smoking the Kool-Aid. I mean, we don't know. So I would say at this point, no, because there are plenty of patients that have mild TR that feel fine, and So I would also clarify it has to be at what cost, right? If we're talking about a big operation, you have to lead them with no TR. If you're talking about less insult, it's probably okay to leave some residual TR.
Dharam, as a clinical cardiologist, what do you think? I know you kind of hinted at we don't quite know yet, but I mean, relief of TR completely?
I mean, intuitively, I guess if you ask someone, they would say, yeah, yes, but I think I agree. It depends on the cost, and if you're creating tricuspid stenosis, even a gradient of 2 or 3 can be significant for the tricuspid valve. So I think it depends on sort of what the risk-benefit trade-off is.
Yeah, and how we do it, obviously, if we have
Right.
to replace it versus repair it.
Right.
Yeah.
And the patient, right? I mean, if we're talking about these 80-year-olds, it's
Yeah.
probably very different than as we see 50-year-olds that we're going to have to treat.
So with a 50-year-old, would you put in a prosthesis to make sure the TR is gone?
As long as you have a good valve-in-valve option, but then you have to start
Okay.
thinking about anticoagulation. I'm not certain about that either.
Yeah, well, lots of questions.
But see, I think that's what the problem
Yeah.
is the fact that we still don't know why some TR is bad and some TR is not so bad, right? Because we all have the person that comes to our clinic who's 70-year-old and has had mild TR forever, and that's all, and then they die with their TR, right? And then we have the 70-year-old that comes and has mild TR, and then you may see them a couple of years later, and now they have this big, large RV and pulmonary pressures out.
Yeah.
I mean, we're so early in its infancy that, I mean, is it comorbidities? Is it some people have atrial fib, some people don't? I mean,
I'm going to go out on a limb and predict that it's all going to be related to the RV. So in other words, a normal RV, you can leave them with a lot more TR, but a bad RV, you're going to have to make some judgment as to what you have to leave them with. Yeah, and it's going to be the coupling, just like the RVPA, but it's about the residual. I don't know. Okay, all right. Thank you, Dharam.
Thank you.
So along those lines about residual TR, we have Brij, Maini, to come talk to us about edge to edge.
You have residual TR with edge to edge?
Oh,
I thought that was,
depends on the patient.
I thought you were going to say the operator. But we know the real answer is the imager.
A lot of residual TR.
Yeah, you just tell her, turn off the color, it's okay.
Yeah, turn the Nyquist limit up, would you? Well, good afternoon, ladies and gentlemen. It's certainly a pleasure and a delight to be here. And these are my disclosures. This is where we began, ladies and gentlemen, in 2014. And Gorav and Scotland, I think, did the first tricuspid clip on the planet. I don't know if Gorav remembers it or not. And then we...
The second one where we got the PA catheter.
Yeah, I know about that, yes. I didn't want to say that, but I'm glad you said it. So we followed closely on their heels, and we did a couple of cases. And by God, we had no idea what we were talking about. As you can see, we have the mitral clip guide coming from above. We've got a clip coming from below. We've got the TE probe down. We've got the ICE catheter in. And at that time, we really did not know that you're not really supposed to do it when you got patient leads going through the tricuspid valve. And you can see there, I'm actually hurting that lead there. But we had no clue as to what we were doing at that time. Now, that does not mean that we know what we're doing right now, but nonetheless. So, I like to plagiarize slides, and this is Paul's fantastic slide, so I thought I'd steal it. And I obviously gave you credit for it, Paul. So since that time, 2014, we've come a real long way. Now we at least know which is the anterior leaflet, which is the posterior leaflet, which is the septal leaflet. And by God, there may be 2 posterior leaflets and maybe 2 anterior leaflets, and who knows which one is which, unless you probably have Becky standing right next to you. Most of us are lost. And of course, Abbott's done a phenomenal job at getting us a newer contraption, if you will. So for those of you who are aspiring to be tricuspid clippers, you really have to understand which leaflet is which, because if you don't know which leaflet is which, you're going to be in a lot of trouble and you're going to have bad outcomes, which is very important to understand. And I love this publication from Becky. This is where we talk about the different kinds and nomenclature for tricuspid valves, and there's a whole grading system, type 1, type 2, type 3A, B, C, and type 4 leaflets. So if you really don't understand what kind of leaflets you're dealing with, you're in for a surprise, and that is where you'll have tons of residual TR. You'll wind up with a lot of badness, embolized, and clips, and so on and so forth, because you'll be at the wrong spot. So I really like these because they really drive the whole idea home as to how important imaging is. And pre-op imaging, intra-op imaging is extremely important. So if you don't have good transgastric views, I don't think this is a good candidate for you to tricuspid clipping on. And you can see the surgical side as to how it's been color-coded as to what those leaflets are. And again, depending on transgastric views, you can explain biplane 3D is phenomenal these days. Make use of it and understand where the pathology is and as to how you're going to attack those leaflets. In the days gone by, in 2014-15, when we started tricuspid clipping, we did not know that you're supposed to clip the septal leaflet and the anterior and / posterior leaflets. A couple of our patients, we did anterior, posterior, and there was no difference in the tricuspid regurgitation. We were scratching our head as to why, how come we did not decrease the tricuspid regurgitation? Well, you're not going to because of the pathology. So being able to guide your therapy based on the echocardiographic imaging is really key to success at this point in time. And these are some of those images, again, from Becky. These really tell you as to how thin the tricuspid leaflet is. And here we go in with this 28 some odd French guiding catheter with these clip arms, which are pretty traumatic, if you will, and we get away with murder from time to time and try and clip those things in. And I'm surprised that we actually have no TR left from time to time, not have more TR left after we are done traumatizing those very, very thin leaflets. So again, to keep going forward, these are different kinds of types of leaflets, and this is again very important thing. We're gradually learning, right? That this is how you're supposed to get these leaflets in. And again, I give credit to Paul, because you really have to know how much leaflet did you get in. And with the newer renditions of the clip, it has become easier versus just the short arm clip that we had in the past. So imaging, yet again, how much clip arm are you really getting into, or the leaflet is getting into the clip? Just a little bit is not enough. Are you going to have an SLDA or not? Well, you may be looking good right now. What about the next day? What about a week later? What about when somebody mentioned the gentleman decides to have pizza and then decides to have 4 beers with it? Are you going to wind up with an SLD? Are you going to blame it on the beer and the pizza, or are you going to blame it on that you did not pay attention to how you were grabbing? I'm going to very quickly show you this case. 30-year-old gentleman came in, had endocarditis, had surgical repair done. They took off the endocarditis and did not do anything much beyond that at that point in time. So I'm sorry, this is going to play fast. I'm not sure why it plays fast, but nonetheless, you can see that this is a lot of tricuspid regurgitation. And what I really want to tell you is a lot of times we think that tricuspid regurgitation is all functional. There's a lot of degenerative tricuspid regurgitation out there as well. And if you look carefully, you will find it. And this is obviously a combination of the two. And you can see, sorry about that. And here's the clip coming in, how important imaging is for you to decide where you're clipping. You got to see those clip arms. If you don't see those clip arms, please don't clip, because it's not going to work. You got to sit perpendicular to the leaflets. If you're going to be sitting sideways, you're going to have a scissoring effect. You'll probably worsen the tricuspid regurgitation if you clip it in a slightly different fashion. So again, this gentleman did well, and you can see one of the leaflets, the way it's buckling, and you got to pay a lot of attention to that, to detail, and that's why these procedures are rather long at this point in time. In this gentleman, we did a good job with this guy. This was, as you can see, was done in 2019. We had mild residual tricuspid regurgitation left behind at the end of the day, and he's done well since that time. So at the end of the day, we've come a long way since 2014, and it's been 8 years, and hopefully the trial Luminate results will be out soon, and hopefully this will become commercial. Even as and when it becomes commercial, I got to warn you, this is a procedure that's not going to be for the faint-hearted. This is not going to be a slam dunk TAVR, as Dharam just showed that picture with those mountains. This is going to be a difficult process, and if you don't pay attention before, during, and after, we're looking at a lot of residual tricuspid regurgitation. Thank you.
So that was great. I think this comes down to the discussion of we're going to leave residual TR, and what do you think needs to happen for edge to edge to get better? Because we're seeing this in replacement trials. Everybody's very quick. Let's just replace it. No residual TR. Looks good. It's quick.
Right.
We don't know the long-term implications yet, but
so I think there's 2 ways I'd like to answer that question. The first is patient selection is going to be based on 2 things. First is going to be, can you image this tricuspid valve, or you cannot? If you cannot image the tricuspid valve, you can forget edge-to-edge repair, because you're not going to get a good result. If you can image the patient well, then you decide, do I think I'm going to have a good result in this patient or not? And that experience is going to tell you, if I put 2 clips, do I put 3 clips on? Am I likely to get a good result in this patient? Then you should do it. And I'm driving to the point is that less TR, residual TR, is going to be better. It may be, that would be a time when you say, you know what, I don't think I'm going to get a good tricuspid regurgitation reduction. I'm going to replacement. Now, having said that, we're all gung-ho about replacement. But again, depending on, as we were mentioning, based on RV function, that is, I think, going to be our Achilles heel. You replace that valve with an RV that is deadbeat or going to become deadbeat. You may have thought it's not so bad, but the moment you replace it, as you guys have seen the surgical side, and suddenly everything goes to hell at that point in time. So I think there's a lot of learning to be had, but the most important thing is image and triage based on imaging.
There's a question in the audience, please.
Thank you.
Imaging is so important for instrument repair, and sometimes key is limited. Should we use ice for every patient when we screen for this procedure?
So the answer, you saw the ICE probe in my 2014 cases. The answer is absolutely yes. But the issue comes is we've learned, thanks to Becky and a lot of other echo stalwarts in the field, as to what angle are we going to use? What is the standard imaging that we're going to use, so that us people, the general folks on the planet that are going to do tricuspid clipping, know what views to use. It would be akin to intercommercial view, it would be akin to LVOT view. We have not learned that on the ICE side. And so my biggest concern is the way you're using the ICE probe is the way you're transecting the leaflets. Are you actually sure that you are in the right spot where you're transecting it? And if you put that clip on, are you truly perpendicular the way we are taught? Or are you sideways and now you have that scissoring effect? So with the 4D ICE catheters, I think that would be the key to success. And we've got a couple of contenders that are doing a fantastic job. So I think there has to be some learning. There has to be standard ICE views. So once we come up with the standard ICE views, I think that would be a game changer. So the answer is yes, but there's a little learning that needs to be had.
And definitely don't look at color with the ICE catheter.
Yes, absolutely. Exactly. Great.
All right, thank you so much. All right, next, I think Molly's going to talk about percutaneous annuloplasty.
So I actually have an easy talk because there's really only one right now anyway, and it's about to start back up in EFS again. So this was put on hold as they re-engineered the device, and as the Pascal TR was getting underway, or the TIR stuff was getting underway, and now it's coming back. All right, so I'm going to start with a case. This is a 78-year-old with permanent AFib, moderate pulmonary hypertension, and a permanent pacemaker. She's 2 out of 4 frail. She had early satiety, 2+ edema, and shortness of breath. Her echo showed severe TR, mild RV dilatation, and mild reduced function. And then this is her TR. And it was deemed it was because, I think because of her atrial fibrillation. I don't think her lead was really impinging on the leaflet. All right, so Cardioband. So these are the 1-year outcomes for Cardioband that was already released probably a couple of years ago now at TCT. So this is now the only device, like I said, that's out there for annuloplasty. We all know that TR is prevalent and undertreated. And this was developed because for surgery, annuloplasty was the predominant surgical technique. All they really needed to do was to put a ring on it, as Steve Bowling likes to say, and they had good reduction in TR. So this is why this technology was created. It looks a lot like a surgical band when you see it under fluoro. It restores the valve to more of a functional state, and when you put the band around, you can cinch it down so you can see in real time how much TR that you can reduce, basically. Each band is measured by CT scan, so it's very individualized for each patient. So this was the EFS. It was for chronic functional TR. Multidisciplinary heart team was needed to be able to discern that it's functional TR that's greater than moderate, so it didn't have to be severe, it was anything greater than moderate. Symptomatic, even though they were on medical therapy, and really everyone knows medical therapy is basically just diuretics, and being an appropriate candidate for the device. And since it was an EFS trial, the primary endpoint is freedom from device or procedure-related adverse events. these were the characteristics. Basically, these, it was predominantly female, as we see a lot in the TR population. They with an average age of around 80 or 78 to 80. And what they found was that that within the 30 days there was no deaths, which was good, and at 1 year there was about a 13.5% all-cause mortality, and heart failure hospitalizations was reduced at 2.7%, and at 1 year, 10%. There was a huge reduction in annular size, which is what you would expect because that's what it was supposed to do. At 1 year, 100% improved by at least 1 TR grade and 73% by at least 2 TR grades. And this goes back to, do you leave some TR or not? And 73% achieved moderate or lower TR. There was also improvements in both clinical and echo data. RV volume was reduced. Most people went to, had New York Heart Association class 1 or 2 from 3. And the KCCQ scores improved, but 6-minute walk really didn't change all that much. So this is what it looks like. So because the tricuspid valve is near the right coronary artery, you have to protect the coronary and make sure that you're not impinging on the right coronary artery. So you have a wire down it, and you're constantly actually injecting to make sure that you don't spasm the right coronary or that you don't cinch it. And if you can see on the right, it's basically screws, and it's attached to a band. The newer device is different, a little bit different than this. It's not really a screw anymore, and it's a little bit easier to deploy. Again, this is what it looks like, and as I said, they measure it particularly for each individual patient, so you can have something like 17 little screws deploy. And as you might expect, this is a very tedious procedure, which was another sort of downside to it. The average minutes in the EFS trial was 180 minutes, so that's 3 hours. And it did take about 3 hours or more to do this procedure to get it right. And if you can see in there, this was the Siemens 3D ICE. And the good thing about the 3D and 4D technology is you don't really have to maneuver the ICE catheter. You basically place the ICE catheter, and then your imagers get to do all the work, kind of the same thing that they do with TEE, and they can get NPRs and things like that. And so it's very, very helpful in this technology. So as you can see in the final view over there, it looks a lot like a surgical band, and then basically we cinch it under echo guidance and watch the TR reduce. So this, as you can see, she went down to probably mild TR, and the picture on the right is actually a 3-year follow-up, so she still has reduced TR. So in conclusions, the Cardioband reconstruction system is a novel percutaneous annular reduction system. The 1-year outcomes are pretty good. There were 37 patients in it. It reduced TR, obviously, also had annular reduction, and there were improvements in both volumes as well as quality of life, which is, I think, ultimately what we're looking for. Thanks.
Well, you know, a 3-hour procedure is surgical-like.
Yeah, it is a little painful.
I'm just kidding. So.
Yeah.
It depends on the surgeon, I guess.
Yes,
Yeah,
depends on the surgeon.
Question for you, though.
No, okay.
Who's the ideal patient for this now? I mean, what's the anatomy you're looking for where you think that you can get a good result? Because we know from surgery, some patients you can put the smallest darn ring on it, but there's so much tenting and tethering that, as you know, that there's still just going to be residual TR. So how are you
It's probably very similar to how you would pick it for surgical. If there is a lot of, if the leaflets are completely tethered, I mean, it doesn't matter how. But if you have good leaflet mobility and annular dilatation, then I think it's fine and actually works really well. But it is definitely based on the type of patient. You can't just put it in everyone. And you know, we had actually all the trials, so we got to, you know, there was some bias, I guess, because we would be like, this one looks like it would be better for an edge-to-edge, or, oh, this one looks better for replacement, this one looks better for annuloplasty. But I think I think we're going to need all the tools to be able to treat this effectively.
All right, thank you, Molly. That was very insightful, and we'll see there's a lot of more enthusiasm, more annuloplasty coming. So next, Firas. Firas is going to talk about replacement. No TR.
No TR. Well, thank you, Gorav. I mean, I really, trying hard, I do not want this to be a debate because I believe in repair and I believe in replacement as well. So I have a debate talk, but this will have absolutely no controversial slides. This is my disclosure, and I want to start by repair is better. So nobody will argue. The surgical literature really support that repair is better. It's lower mortality. This is meta-analysis that's been published. However, we just need to understand that most of this data is from the surgical literature and it's not transcatheter. And the age is a little bit different. You know, with the surgical repair, the patients were a lot younger. All of the patients who are enrolled in the transcatheter trials right now are older. Clasp TR, 76, Triluminate, 78. Cardioband, Molly just presented, the age was 77-year-old. And Trisend, which is the replacement, is 79. So it's much, much older patient population, and I'm not sure that this is the right patient population to address longevity of a repair or replacement. Most tricuspid surgery is done in the setting of functional TR, in the setting of left-sided disease. As we know, isolated tricuspid surgery is not that common, and endocarditis was the most common indication for isolated tricuspid surgery. I also believe that the surgical mortality has dropped significantly, and in the right hand, you know, right now it's a lot less than what is published in older literature. However, it was deemed to be a high surgical risk. The recurrence of TR happened, and regardless of what ring was used for repair. So the management of the tricuspid regurgitation, really there is a huge unmet need. And medical therapy for severe and more tricuspid regurgitation is limited. Surgical intervention is not used, is not as common as the disease prevalence is. And there are multiple factors for that. One is we don't really understand the etiology until very recently. Mortality has been high. Referral is very late. As we heard from many people, when the RV dysfunction is profound, we're already too late. And transcatheter intervention was recently added to the European guideline for treatment of severe symptomatic TR in inoperable patients. What we have seen this is the mainly repair literature, is that it does not eliminate TR. It decreased TR, it does not eliminate it. It improved New York Heart Class Association for sure. And maybe we start seeing a signal to improve mortality by reducing tricuspid regurgitation. There is a lot more data that is coming up. This is just the tip of the iceberg. But I think this is, to the point that was made earlier, this is where the future is going to be exciting. The problem with repair is obviously the residual TR. There is definitely, depends on what study you look at, the majority of the patients still have moderate plus tricuspid regurgitation. And the same holds true for cardioband as well. So really, this is why there's multiple transcatheter devices that are under evaluation for different anatomy. We agree that one device cannot fit all anatomy, and we just need to determine the efficacy and the safety. The comment about at what cost is so true, because we need to make sure that the therapy that is going to reduce TR is safe for a disease that we are really not sure what is the long-term sequel of. And the patients have to be suitable for transcatheter therapy, need to be looked at. This is a patient that has massive torrential. What do you think, Nadira?
Definitely torrential.
Yeah, this is where interventional cardiologists can say, well, this is really bad TR, and there is a lead that is in the way, and the patient has a left-sided replacement, and it made imaging extremely difficult. As you can see, we really struggle with the replacement, with the imaging. This is thought it was to be pacemaker mediated as well, so it was not great candidate for TEER repair. This specific patient was treated with the Intrepid valve, and as you can see, the brim of the valve is deployed. The valve was deployed at the annulus under rapid pacing, and within 20 minutes, the patient has a new valve with no residual TR or PVL and a very acceptable residual gradient. So we also learn from multiple registry who is not suitable for repair. Those are with really big gaps. Those are who has a tethered leaflet, and we start getting smarter gradually in selecting patients for therapies. What is also was brought up, Molly brought the 3 hours, and I think Paul ran away before I tell him about the 3 hours on tricuspid repair as well. But it is really, the procedure times matter, because you put those patients under general anesthesia, TEE, pump them with fluid, and if we look even with the early experience, with the repair, the time was like 167 minutes as opposed to roughly about an hour with the replacement, with similar stages of knowledge. The EVOQUE tricuspid valve also is probably the valve that has the most number of implants to date. The trial is in the pivotal phase, and it's enrolling really fast. It is a completely different mechanism. It relies on anchoring underneath the leaflet, and the valve is deployed from the ventricular side to the atrial side. It is an over-a-wire delivery system, and the trial is enrolling fast in pivotal. The early feasibility was recently published, and as you expect from a replacement therapy, there is elimination of tricuspid regurgitation with extremely low mortality rate and improved in New York Heart Class Association. So in conclusion, both repair and replacement are in the future. Most of the available tricuspid repair data is from surgical literature, and the tricuspid patients that are treated with transcatheter therapy are generally older and sicker. Replacement is more efficacious and predictable with shorter procedure time, and repair might be safer, but replacement is not far behind, and ongoing trials will help answer some of those questions. Thank you.
Thank you, Firas. So while the rest of the panel is coming up, I guess, Firas, in your practice, where do you see currently repair? Which patients are you thinking about repair, since you've had such a great experience and run with different replacements?
I think and that is a very good question. I think that, I totally agree with the comment that repair require better visualization than replacement. And, I think if the gap is big, if the leaflet is tethered, if there is a pacemaker in the way, those patients that we shy away from repair. And, we try to get them into replacement. I really worry that, when we look purely based on anatomical consideration for repair and replacement, we have a selection bias, and we're treating patients who might actually benefit from the other therapy should it have been feasible for them.
I'm actually curious from everybody on the panel, everybody here is involved in various tricuspid trials. Are you starting to see patients earlier on in their disease? Are they getting referred earlier that may be now more eligible for repair than initially where you saw, you just had triluminate, that's it. That was the first one out, and a lot of patients just screened out, they were too far gone. Are you seeing any change in the practice?
I would say yes. And actually, I think more people send tricuspid patients than they do mitral patients. For some reason, I think it's easier for doctors. They're like, oh, tricuspid regurgitation, and they send it, and they still don't know what to do with the mitral. It's weird. Our
They
clinic,
think they do.
Yeah, our clinic is like, I feel like my mitral clinic is 80% tricuspid. So I think that, yes, there, and which is, you also see in the enrollment. So, I mean, this one, Evoke, is flying through its enrollment, and it's easy. It really is easy.
Yeah, if we didn't have the pandemic, triluminate would have been done a year ago.
Yeah.
You know, and it just closed last week. I mean, I think it's really amazing because TR, most people just kind of throw up their hands.
Yeah.
And you're right, mitral people tend to think they know what to do.
Yeah,
And
or
so it's
something.
kind of the absence of guideline indications, which make it a little bit easier. Omar?
So I would say yes and no. I would say yes when people are recognizing that it's severe, and then yes, they'll send it, whereas maybe before they would just wait on it and then it would become torrential. But I think there's still a lot, and we're all at good centers that I read where it's clearly severe and it was not read as severe. And I think that's all the quantitation that Nadira talked about and the recognition, and that part needs to be enhanced a lot more because I think although we're getting more, we're still missing a lot.
All right, thank you.
Can I say something real quick?
Yeah, please.
So,
Omar, come on up while you're.
So I think what's funny about that is I feel like that doctors have no problem sending mild or moderate tricuspid regurgitation. Like they don't know, they just send, but they're afraid to send mitral, and then because they can't quantify it. And so I feel like that they think it's mild or moderate and it's really severe mitral, and they just sit on it. But the tricuspid, they just, yeah, send it.
Well, they don't know what they don't know, I guess.
I like your doctors that are sending, just send it.
So we've all heard allusions to this talk, so we're waiting for it. Omar, tell us when the RV is too gone.
Okay, don't get your hopes up too much. It's the green button?
Yes.
All right, here are my disclosures. So RV function, we're going to talk about a lot. So what are the determinants of RV function? Preload, which we know is increased in TR. Afterload, which is reduced because we have a pop-off. And then there's contractility, which is the muscle. So how do we define normal RV function? That's one thing. But the other thing I want people to think about, and we may not necessarily have an answer all the time, do improvements in RV function always correlate to improvements in outcomes? So in general, this is a multimodality table, but if you look at the most commonly assessed things, so an RVEF, the most simple parameter of greater than 45 to 50% is considered normal in general. Additional echo measurements, which were already shown, TAPSE, so with the cutoff of 17, we have RV fractional area change, we have systolic tissue Doppler, we have RV free wall 2D strain, and I'll go through some of these. So these are all parameters from the echo guidelines. We have a little bit of data now in the natural history of TR and outcomes. This is a recent CMR study. And what we do know, and I think Firas was talking about this, is there's this high-risk group. So we know that when the TR volume is greater than 45, let's say, and the fraction's greater than 50%, there's high risk, and then there are these other categories. But this is just, remember, watching these patients over time. And the other question is, what is the TR correlation with EF, which is not always so clear. So going through a couple quick studies, I'm going to keep it very simple. This is a study of prognostic value of cardiac MR imaging preoperatively of patients with severe TR, and the prognostic cutoff they came up with here was around 46% for RVEF, which would be mildly reduced by current parameters that are in the guidelines. This is another CMR study where they looked at RV-EF before and after in both repairs and replacements. And what they found was that EF was unchanged after annuloplasty statistically, 43 to 47, and it was lower after TV replacement, 52 to 42. But again, probably TV replacement patients had worse TR, and those parameters weren't reported. So probably their RVs were worse off in the first place, more tethering, et cetera. This is some echo stuff. So this was another study on prognostication using RV free wall strain, which is turning out to be a pretty simple and useful parameter on echo in many studies. And this said free wall strain less than 24% was associated with poor surgical outcomes. But 24% is still a pretty high number. I mean, it's only mildly reduced. So transcatheter studies. So we have a couple studies from the Tri-Valve Registry, which was a registry of a bunch of tricuspid interventions. And there's some confusing data here. So in this first study, it was propensity matched, and there was a mortality benefit for these devices only in the middle RV function group. The thought was that the worst function group was irreversible, and maybe the normal function group was too good. But I would also pose that RV function was only evaluated by one simple parameter of TAPSE, so not very extensive. Similarly, for this paper from Tri-Valve with RV dysfunction and pulmonary hypertension, they really didn't find any association between RV function and outcomes, but again, only measured by TAPSE, so very, very simplistic. So what about RV function in the setting of TR, right? RV-EF being the simplest parameter. So how do we define normal RV function? So I have patient A on the left, which has an RV-EF of 50%, but all of the stroke volume is forward. I have patient B on the right, where RV-EF, right, RV-EDV minus ESV is 50%, but half of the stroke volume is backwards. So this is a pseudo-normalized RV-EF. So then we'll get into a newer concept of what is the effective RV-EF. So on the left, it's 50%. On the right, it's only 25%, because that's what's effectively being pushed forward to where it needs to go. So again, effective RV-EF, simple formula, forward flow divided by the RV-EDV. So it's basically discounting the TR that goes back into the atrium. So this was a study that actually looked at this a little bit. Looking at, again, surgical correction. So the MRI before the procedure, pre-surgical RV-EDVI, so EDV indexed, less than 164 ml per meter squared, which is a pretty high number again, predicted return to, quote, normal RV function. But what you notice in the table below is that the traditional RV-EF really didn't change much. I mean, it dropped a little bit. But the effective RV-EF went up quite a bit. And you know, it depends on RV dilatation and everything, but I think this is probably the way we need to go. But looking at another study, which kind of followed patients with significant TR, so an observational study with a follow-up of 3 years, effective RV-EF had the highest area under the curve for outcome prediction. And furthermore, these Kaplan-Meier curves separated out with an effective RV-EF of 34% as the cutoff, and this was the strongest predictor of outcomes on multivariable analysis as a single parameter. So 34% kind of makes sense to me. That looks like a bad number for RV function, whereas some of the traditional RV-EF CMR studies doesn't look like such bad numbers, so those become confusing. So I want to touch upon RV fibrosis. So this is something that sometimes is looked at as a panacea. We do this on the left side. It's a little harder to do it on the right because the walls are thin and hard to see. So this was a study from 2015 looking at ECV, which is interstitial fibrosis, which correlated with RV dysfunction. So a fairly simplistic conclusion in patients with pulmonary hypertension. So 7 years ago, but this work has not been really reproducible. So I think it's pretty hard to do. But certainly worth looking at more on whether this is additive. So is anybody clear? I'm still confused even though I gave the talk. So when is the RV too far gone? So we have some basic parameters in general that we see through these studies. So EDVI, effective RVEF, which I like better than regular RVEF, free wall strain, a very simple parameter which you can get from any echoes with the right software. I think it's still up in the air. And another thing which I didn't include a slide on, but I think the transcatheter space is a little different than surgical because there's more variability in the devices and how it's going to affect your RV mechanically or otherwise. You could have a replacement with different designs that could interact with the leaflets, the annulus, the RV mechanically, or you have on the other end a cable device which doesn't interact with anything. So I think that's something that still is being investigated and probably, I think, has an impact. I mean, we've all seen replacement devices where it's just pushing on the RV base and it just looks strange and you wonder what's going to happen to that patient in the future. So I've had the pleasure of working on this CT and CMR sub-study within the Triluminate trial with Paul and Joao and others. So I think we'll get some of the answers here, I'm hoping. There's going to be a sophisticated analysis that is being done and will be done. So hopefully this talk will be more clear in the future. Thank you.
I really like that effective RVEF. So that's really neat. So, but tell me, is that a different way of describing forward stroke volume?
It is. So it's a different way of basically excluding what goes backwards and just codifying it into a simple formula.
And do you think, I mean, is forward stroke volume an easier way just to think about, or do we have to index it to the RV volumes as our effective RVEF does?
So as we've all seen that the stroke volumes tend to be low, but I think that there is an indexing that's needed because I think that tells you how much of your total dilatation you're really ejecting.
And how easy is it to calculate that for the lay echocardiographer, an effective RV, and how labor intensive?
So this would be a CMR metric because you can't really get RV EDV.
So when are you going to change that, Nadira?
Yeah. I mean, I think we can debate about other subjects, other places, but I think in TR, really CMR has to be a screening tool because of the complex shape. We cannot get accurate
And then, of course,
volumes.
40% of them have leads, and you have to worry about all that, too.
Correct, there's that issue too, but we can avoid that with different technologies, but I think in terms of getting the volumes, overall, CMR needs to be a screening tool for this population.
All right, well, great talk. Thank you, Omar. Next, Paul's going to talk about clinical trials and the science of tricuspid regurgitation.
Thank you very much, Gorav. So I would talk a little bit about the ongoing trials and a little bit about the science of what we expect to learn from these trials. Here's my disclosures. So when we talk about guidelines, I think this is probably part of the reason, or a major reason, why a lot of physicians just throw up their hands when they see TR. And that's simply because when you look at the list of guidelines, there are no class 1 indications for isolated TR. You've heard about diuretics, and diuretics is kind of the mainstay. But otherwise, when to refer patients for interventional therapy, we actually don't have really good guidelines at all when the TR is in isolation. Now, the Triluminate pivotal trial, which has been mentioned, is the first pivotal trial for TR reduction, and I have the pleasure of doing this with Dr. David Adams and many people here. And there are two arms. There's a randomized arm in which patients are estimated to get to moderate or less, and they're randomized versus medical therapy. And there's a single arm in whom the TR is much more severe, and in those patients, everybody gets the device. And we're aiming to show these results this coming spring, and I can't tell you how excited I am to finally get to see what we've done. There are also two other important trials that are out there. Excuse me. There's a TriSend pivotal trial, which is looking at the Evoke device. It's also a 2-arm trial with a 6-month and 1-year outcomes, as one can see there. And there's also the CLASP TR pivotal clinical trial, which is very similar in a randomization versus medical therapy with the Pascal device. And this is a 2-year outcome study with the endpoints as listed there. But the point of these is to show you that there are a lot of pivotal clinical trials for TR. And I think a lot of these questions we're kind of batting around to each other, we're going to learn a lot about over the next several years. Because I think percutaneous therapies really give us enormous opportunities to do things and study TR unlike ever before. So here's an example. So when we're thinking about these trials and how they're randomizing against medical therapy, for the first time we're testing the impact of TR reduction. These devices, which are incredibly safe, permit that randomization. And I think that's what's really great about having a transcatheter option, that in which we can randomize and see what the effects are. There's also optimal GDMT, which is being insured. In Triluminate, we require a right heart cath for all of our patients. And there's relatively broad inclusion criteria. We have intermediate risk patients, patients with PA pressures up to 70, EFs down as low as 20, and we're including pacemaker leads, which actually currently compromise about a quarter of the patients being studied. We're looking at new clinical pathways with the science of these trials. We're describing TR quantitation in ways that have never been described before. So Nadira gave a laundry list of parameters, which I still have a dizzying way of trying to get around, but we're describing in ways besides just saying it's severe, and I think that's really important. There's a new nomenclature, as Brij talked about earlier, where it's not just about saying that the leaflets are this and that, but looking at anterior, posterior, septal, looking at Nadira's way of describing type 1 to 4, multiple segment leaflets, and many ways of describing these things. And these treatments are really important because what's out there is not so great. You know, if you have Gorav Ailawadi at your institution, it's one thing, but for most centers, the risk of TR surgery is not low, and it can be actually quite significant. So we have a lot of TR patients who are at high risk, and we need to do better. And as Nadira mentioned earlier, these trials are going to help us define what is meaningful. You've heard about repair versus replacement and about residual TR. You know, there are multiple grades now, up to torrential grade 5. It's really interesting. So in the Triluminate EFS, I was going to mention this earlier, that if one goes from stage 5 to stage 4 with TriClip, the KCCQ score improvement is the same as you go from 4 to 3 or 3 to 2 or 3 to 1. It's 15 points. And so that quality of life improvement, even when you have residual massive 4 TR, what's that going to mean? I think we're going to learn a lot about that. And we're going to study it in new diagnostic ways. As already mentioned, we have the imaging sub-study, and you've already seen this slide that was shown earlier. We're doing CT, MRI simultaneously in these patients. And here to Gorav's point, you can get minimal residual TR. So this is a great case example that Joel showed before. This is an MRI baseline, an MRI done just 30 days after TriClip. There's a pacemaker lead that's in the way. And then if you look at the top right there, there's a bloom from the TriClip. But there's no better way of looking at volumes. And this is what Omar was mentioning earlier. Look at these RV volumes, 237 down to 166. Regurgitant volume of 86 at baseline. And Joel tells me he can measure 2 mLs, which I think is quite amazing because I don't think Nadira can. I'm just kidding. But so the regurgitant volume is 2. But look, internally consistent data. The RV diameter has already shrunk from 50 to 44 within just 30 days. And so we're going to learn a lot about what we can do with these therapies. And so with that, I'll leave it at that for the clinical science.
Thanks, Paul. I think certainly the most compelling point is just the improvement in quality of life, even with just minimal improvements in TR. Do you think, so on the science side of it, why do you think that is? Is it because of the RV ultimately? Are there some patients who even the reduction won't have any impact? We've seen some patients that gone from torrential to no TR with a replacement, yet they struggle.
I think the RV is, it's generally a forgiving chamber in that there's a lot of plasticity. And we know that even with just small changes in diuretics, even in a procedure, if you add a little PEEP or tilt the patient 10 degrees, you can dramatically change the TR and change the gaps. And so there's a lot of variability there. And I think when we think about those patients with grade 5 torrential, it doesn't take much to bring them up the Starling curve because of that. But I think what's most interesting is that, and I learned this from Dave Cohen a few months back at TVT, and he said that a KCCQ score of 15 points is almost always associated with improved survival. And I said, well, that's interesting. So if they go from grade 5 to grade 4, then we've impacted survival. And he said, well, we got to see the data. And I said, and that's fair, and that's fair, that's very fair. But it's really amazing because quality of life improvement almost always goes with survival improvement, especially when it's that degree. And so we'll see. And I think this discussion about residual TRs can become even more germane.
Absolutely. All right, let's go on to the next. Is there a comment?
Dharam.
Go ahead, please.
Just a quick question. For the trials, for mitral, as for the functional, there's a lot of emphasis on GDMT and sort of titration. Yeah. How do you handle that for the tricuspid trials? What is GDMT for tricuspid? What does it look like?
Well, there's so for TR, Molly's absolutely right.
Fix the MR.
We require diuretics, but we actually, in the right heart caths, the wedge pressure is supposed to be less than 20. And they're supposed to also have a review by a heart failure specialist to say that the GDMT is optimized. It's different because, in COAP, the EFs are abnormal, but in triluminate, they can be normal or abnormal. And so, but if they have left-sided LV dysfunction, they're supposed to have the same GDMT requirements as COAP.
Great point. All
But
right.
I think that we have to be careful, though, comparing to surgery, because all that surgical data is so old, and even the surgeons have learned from our percutaneous. I mean, at least in our hospital, I know a lot, I know in Gorav's too, I mean, they don't operate on a TR patient unless they've optimized them, and that was something that they didn't do before, and they're very specific about picking the right patients. And I think if you did a lot of the surgical TR isolated studies now, I think that the mortality wouldn't be as high.
In fact, Molly's group has a paper like that
Yeah.
shows a 3% mortality. So, great. Next, Vinny Bapat's going to talk about tricuspid valve surgery, current and future state.
I think surgery is gold standard, as you just heard. So I don't understand this 2 ml, but anyway, I never understood 2 millimeter below the annular caesar. So I think, just jokes apart a bit, but I think this is a challenging field for sure, and this is just to show you what Molly just mentioned, a lot of historical sense of how tricuspid was managed. And I think we all agree very well that medical and surgical management were the only 2 options. And with transcatheter work being done, and not just in terms of treating it structurally, but also understanding physiology is definitely going to move this bar somewhere else. These are just to understand classification and stages, essentially primary and secondary, and most of the surgeons, we usually get involved in secondary TR. Primary, of course, one of the recent data analyzed from 2 of the centers I worked with, we found surprisingly that the primary TR pathology was not that uncommon, but if you call pacing lead into primary, then it would be as big as 35%. The stages, of course, is B, C, and D, progressive, asymptomatic, severe, and symptomatic. These were important to understand surgical interventions. Recommendations, many of you know this chart, but I'm just going to split it into something simple. So the recommendations of surgery are based on repair or replacement, but if you look at it, majority, the assumption is repair will be done more than replacement. Ring will be used instead of suture-based repairs. And again, it's a different conversation in Western world versus Asia, because Asian patients, a lot of rheumatic heart disease, young patients, they still get suture-based repairs, because once you take care of the mitral, pulmonary hypertension disappears. At younger age, the remodeling is much better. But in Western world, it's very different. We see more of degenerative MR or MS and left-sided pathology. And another assumption, of course, is that the pacemaker rates are not influenced by repair. This is, again, there will be a discussion among surgeons probably what kind of rings they use. Replacement, in my opinion, at least now with valve-in-valve being available, maybe this conversation might even change, because you can implant a tissue valve in these patients and have a reasonable platform for a transcatheter. Unlike the transcatheter or surgical repair, most of these rings are not suitable for valve-in-ring. So let's take the simplest of the recommendations. I think most surgeons will agree on that. If we're doing a left-sided surgery, a patient has already stage C or D, these patients nowadays definitely get a tricuspid repair. And I think, Gaurav, you will agree that this percentage is increasing every year is with the STS data. In Europe, it's becoming common as well. It adds to around 30 minutes of clamp time, and sometimes you can do this even on beating heart, depending upon your experience. And this will definitely impact patients' mortality and morbidity in future. This is how the repair is done. The idea is to prevent further TR and not wait for the left side and lung pressures to go down and allow essentially RV to work better. Progressive TR, stage B, if concomitant surgery is done and patient has had prior hospitalization for heart failure, sure, this is another indication where most of us do tricuspid repair. Isolated tricuspid repair, again, is debatable, but if you have patients like this, who have isolated tricuspid regurg, who you have done everything possible, these are the patients now probably exclusively go towards transcatheter repair. So, but what's very clear is if you have a left-sided disease, and this is important, and if you look at tricuspid trials as well, you know, impact of left-sided disease is critical when you are enrolling a patient. Because what you don't want to do is, you know, spend a lot of energy and effort into treating the right side, and then when the left side impact is still intact. And there are some predictors in terms of larger annular size, how you measure it surgically or by echo, and maybe in future by CT, RV dysfunction, AF, pulmonary hypertension, and more importantly, leaflet tethering. Again, there are two publications in surgical literature. One believes that one should repair even patients with dilated annulus without any TR. And again, there is another publication which says patients probably don't benefit if you do it in all. So I think this literature is just evolving, and I think more data needs to come out in terms of what we are doing surgically, is it appropriate and timely as well. So finally, the secondary TR with prior left-sided surgery. This is the most difficult group, because if you send me a patient who has had some surgery, either CABG, mitral, or aortic mitral, and this patient has TR, these are the patients who are very challenging, and these are the patients who have highest mortality and outcome is worse. So this is the difficult group, and this is where I think the transcatheter work is really making or going to make a really big impact. Primary TR is again uncommon, but sure, we see it, and if the patient is a suitable candidate, they have reasonable and good outcomes, again with minimally invasive options and with no RV dysfunction and lower pulmonary hypertension. The mortality in literature is 1 to 2%. These are some of the examples of patients with pacemakers, and I think we all have seen patients with pacemaker who have TR, a lot of them because of either septal leaflet tethering or even leaflet perforation, caudal entanglement, etc. So if you look at multiple patients who come through, this is the Mayo experience, and Paul, probably you were there that time, pacemaker-induced TR was 42% and associated was 58%. So this was the split. And they did multiple different types of repairs, and these can be challenging, like patch repair, taking it out, or lateralizing the pacemaker outside the ring, or even within a commissure, which is most of the time I do. But this can be done, and you can get a robust repair. Again, the follow-up was not more than 2 years. 30-day mortality in these patients was still quite high. This is just our case from 2 weeks ago. This is a pacemaker-related TR. Patient also had a left-sided surgery. You can see very beautifully two things. The pacemaker has gone through the cords, but more importantly, I think an initial attempt at placing the pacemaker must have perforated this septal leaflet. So what we did essentially was, we took out the lead and then patched it and then repaired the tricuspid and put an epicardial system in this patient. Isolated tricuspid surgery, this is the trend up to 2013. Probably Gorav can tell us a bit more about what has happened after that. But there has been a steady increase. In-hospital mortality still is high. And funny enough, the repair and replacement is 50-50, which is interesting to see. Maybe it's related to whether it's pacemaker related or not pacemaker related, or longevity of the patient as well. I have low threshold. If I think the patient's lifespan is going to be 10 years or less, I might as well replace the valve so that I take care of it once and for all. So isolated TB surgery repair in this is less. I think you can see the mortality is less. Replacement mortality is a bit higher. Maybe these patients were sicker in that phase of up to 2013. Reoperation risk is very high. I think this is that patient's population I was talking about, left-sided surgery or some other surgery before. And I think the outcomes logically and common sense really, RV dysfunction and pulmonary hypertension is always bad. So to conclude, in primary TR, I think one should not wait for too long. And the outcomes of surgery are better if you operate earlier. If it's with pacemaker lead, again, make a judgment call on can you repair it properly or you should just replace it. And for secondary TR, concomitant secondary TR is commonly repaired now. Rigid ring or semi-rigid ring, whatever, I think surgeon's choice, but a ring annuloplasty seems to be more durable. There's minimum impact on the outcomes if you add that to a left-sided surgery. And I think timing of surgery and defining triggers is going to be really very important in future. Thank you.
That's great, Vinny. So I know that the data on TR concomitant surgery at the time of left-sided disease is a little ambiguous in terms of what to do if it's not severe. I want to ask you though, a lot of our patients that come to see us with TR, they're re-ops. And they're re-ops from 7 to 9 years ago, and they have post-op AFib that never went away. They have hypertension. They essentially have HFpEF that then leads to the TR. Tell me, what is the additive risk of just throwing on a ring, even if the RV is not enlarged or if there's not any TR?
So I think 3 years ago, I would have answered it differently. And I keep always thinking of what's the second intervention if needed now. So when we surgeons say surgical repair, it's usually a ring. And all the tricuspid rings in market currently are incomplete and they are rigid. So they are not very good. If the TR recurs, what do we do with them? I just got a call from Azim just 20 minutes ago. I've got this patient with this ring, what do I do? It's too small for Intrepid, slightly big for Sapien. So I'm a bit confused myself at present. Like by repairing it when there is no TR, am I actually doing a disservice to this patient? Because you can't put a clip or a Sapien or an Intrepid. Or the second thing which me and Gorav have been challenging a lot of surgical industries now is, why don't we just give us a ring which is suitable for future TAVR intervention? So I think we need to change that tactic. Yeah. But at the same time, most surgeons will not hesitate if it's a moderate TR, and there's a mild TR and there is leaflet tethering or annular dilatation, that we will do a ring. But my choice of ring is changing slowly. It's becoming more semi-rigid, or I'm thinking of more creative ways of creating a platform by which I don't close the door of transcatheter valves.
Question from Al.
So we know that AFib presents to have a fair amount of PR. We know that some of these patients come for redo and they've had chronic AFib. Should we think more of MACE procedures at the time of first agreement with the setting of AFib or paroxysmal AFib? Or should we do more MACEs at the time of tricuspid repair if patients have certain signs of right atrial or left atrial?
Right. So, means the whole atrial MR, atrial TR is based on the fact that the fibrous skeleton of the heart becomes larger because of atrial pull. Same as if you think of LV enlarges, it leads to tethering of subvalvular apparatus. When we do MACE procedure, the concept of MACE is to increase atrial transport. I'm not sure is going to add in terms of, the stability of the fibrous skeleton. Other than, rhythm gets sinus rhythm, but necessarily LA or RA rarely remodels. Means you see that in rheumatic patients, by the way, but not so much in degenerative. The second thing is when we do MACE procedures, most of the time it's with mitral surgery. So we have already put a ring which is stabilizing one part of the fibrous skeleton. So this is a very interesting thought in terms of when we do the annuloplasty on the mitral, and Joab and me have been thinking about this for some time now, whether it pulls the tricuspid fibrous skeleton a bit more towards mitral and adds to this issue. So it's very complex, but it's something we should, probably Steve can comment on it. Steve has done this more than anybody in life.
No, I mean, I think you're absolutely right, but I would say most of the surgeons now, I mean, first of all, the patient has AFib, for God's sakes, to move me. Each report itself in the state. The second thing is I think everybody's threshold of putting a tricuspid ring on, and it's even lower in patients who have AFib and any TR whatsoever, to the point where now if somebody is getting a maze and has a slightly dilated angles without TR, I'll put a ring on it. I won't hesitate to do that. And I think he's absolutely right. It's all about stabilizing the whole central skeleton of the annulus that doesn't allow it to pull back open. So I think, but that's easy for us to say because the surgeons in this room do a lot of this. The average number of tricuspids done per surgeon in the United States of America per year is 0.8.
I mean, that's really an incredible perspective. But along these lines in discussion, I think it's really key. If you look at the transcatheter TR trials, almost all, I haven't come across a trial yet in which the prevalence of AFib was not 97%. They're all 97, 99%. Everyone has AFib for the transcatheter TR trial. So, I mean, it just begs the question is that if we're not doing enough for AFib earlier on.
Well, I think the Affirm trial was the worst thing that ever happened to us. That rate versus rhythm control, because it only went out, 5 years? And so, rate's okay. And then all these people have TR now. I think that's a horrible thing to have happened.
But is it like, most aortic stenosis patients die when we are old? So I think the thing is AF the cause, or it just, by the time we see these patients, the disease has progressed in so many ways that I think that is the main question. But this is evolving. I hope that 0.8% will slowly become 18% as the time goes. Thank you.
Okay, thank you, Vinny. All right, last but not least.
All right, great perspective, Vinny. Thank you. So I'm going to talk about the prediction for the future. Here are my conflicts. So there's a lot of moving things going on in the tricuspid space that we've heard about. First, we know patients are referred late in their disease. We've heard historically the outcomes are poor, although as Molly's group has recently demonstrated, isolated TR outcomes now have a 3% mortality when carefully selected, preoperatively optimized. We just are reporting our tricuspid replacement, isolated tricuspid replacement outcomes at the University of Michigan with a 6% mortality instead of the 13 to 18. There are obviously numerous transcatheter trials. Patients often with TR have concomitant disease. And then we know all the other things that impact survival, as TR is purely a marker of liver disease, renal dysfunction, RB function. So we know historically that things like liver and kidney disease have an important prognosis and outcomes. This is an early study that we did looking at preoperative MELD score in patients undergoing tricuspid surgery, and when you have a MELD over 15, the mortality jumps up substantially up to 25 or higher percent. We've also developed a risk calculator. I think many are starting to look for this in our populations. This is using data from the state of Michigan and the state of Virginia on all isolated tricuspid valve surgery and using STS data predictors, coming up with a clinical risk score, and this risk score then it correlates with mortality. There are now many transcatheter options. We've heard about many of them earlier today, and I won't go in a lot of detail, but we've seen great results with Cardioband, and unfortunately, there you go, it's playing on the right. And again, carefully selected patients. That's why I asked Molly, who are you picking for this? We don't always get that result. And then with Pascal or edge to edge, you can also obviously get an excellent result when there's great imaging. And then there's obviously a lot of enthusiasm with replacement devices, both with Evoque as well as with Intrepid tricuspid valves. So what is the role of surgery? We heard from Vinny, a great overview of the guidelines and predicting the future. You know, the way I think of this now, it's in terms of isolated tricuspid patients who we're seeing that we're operating on. First are patients that are not eligible for transcatheter options. So obviously endocarditis, perhaps some younger patients, although we don't see a lot of younger patients with functional TR, but patients that are screened for transcatheter approaches and they screen out. And honestly, that's pretty common that Dr. Bowling and I are both seeing a lot of those patients, then operating on them. And of course, concomitant disease, if they have complex mitral disease with TR, I mean, all of us are seeing that now. They're not eligible for either trial because they have the other lesion, so their only option is medical therapy or surgery. So this is I'm going to just share a few cases. This is a patient had severe to massive TR, had a pacemaker lead, had a long-standing history of AFib for over 20 years, very, very large atrium, was not eligible for transcatheter therapies. Now, I will admit this is a little bit further on back in time, so maybe more options exist now. And this is actually his case. And Vinny showed some nice options with leads, whether to remove them. I tend to actually keep them in place and sometimes use them for the repair if they're actually adherent to the septal leaflet and use it to actually increase coaptation. In this particular patient, the lead was mobile, but we can, under a beating heart condition, test the valve and look to see where does the lead cause the least amount of impingement of TR and tack the lead to that location. So that's what we did here, and then we tested it, and he had a nice result at the end with really no residual TR. It does come at a cost. This is still surgery, even though it's less invasive, versus the transcatheter approaches, and this patient still stayed in the hospital about 5 to 7 days. There is certainly more and more experience with less invasive approaches with tricuspid surgery. We've looked at our own experience, and we know in general and in the literature, when you're doing a concomitant mitral and tricuspid operation through a sternotomy, and this is on all comers in the state of Virginia, so this is not necessarily in highest volume centers, the mortality is higher when you need to do a tricuspid operation. However, with less invasive approaches, we may be able to decrease that risk. What about concomitant disease? And Vinny alluded to some historical data and kind of what set the stage for the Cardiothoracic Surgical Trials Network performing a randomized trial in patients with moderate TR undergoing degenerative mitral surgery or dilated annulus with less than moderate TR. And this has been published earlier this year. And we found patients that had concomitant tricuspid annuloplasty had less progression of TR. And this is shown here. This is now out to 2 years. The column on the right was the mitral valve surgery plus tricuspid annuloplasty. You could see substantially less progression, with almost no patients getting severe TR, progressing to severe TR, and very few patients even having moderate TR. So we can absolutely make an impact in these patients. So concomitant disease is still, as I mentioned, a lot of what we see now that we don't have good options as yet to treat both. Unfortunately, I don't know if you can play this, but this is a patient that had a previous ASD as a child and presented pretty late in her course. She's now in her 70s and had a really massive atrium. You could see actually a large residual ASD, left to right flow, severe TR, and you can see the IVC size was 3.1 centimeters, so very large. You can see her CT scan, massive pulmonary arteries, and you can even see the gap in the residual ASD shown on the CT scan on the right. So this patient underwent mitral and tricuspid repair and ASD repair. Again, this is more of that functional TR, atrial TR, that I think we're catching on quickly, that probably has a better result with annuloplasty because they typically have a lot of leaflet tissue. So where I predict the future, you've already heard from Paul and others. These devices, transcatheter devices, are coming. How far away is edge to edge? I put in 12 months. I'm hoping it's less than 12 months for the first commercially available device. In terms of replacement, somewhere in the next 1 to 2 plus years. And in my opinion, surgery will really end up being reserved for ineligible transcatheter patients, young patients that we may want to consider, and there's already been some thought and discussion amongst both the surgeons as well as the different valve companies. Should we be thinking about a trial against surgery, as I do think surgical outcomes may be actually better than they were historically. Endocarditis, and then of course concomitant disease. So with that, I'll end. Thank you.
That's great, Gorav. So you're the PI of some notable pivotal trials right now. How easy or hard it will be to randomize somebody for TR, transcatheter versus surgery in that age group?
You mean once commercial devices become available?
Yeah.
Yeah, I think it's going to be very challenging. It's probably not that dissimilar than what happened when one of the TAVR devices became commercially available before the other. So I think we all have to ask in the spirit of science to try to continue to enroll, but it will be challenging. I think in some ways, if the first being an edge-to-edge repair, there's probably going to be very select patients that are going to be eligible, and that's going to depend on imaging. It's going to depend on the site that has good imaging, good proceduralists, and so that may not have as much of an impact until the first tricuspid replacement, where it's quick, easy, and quick and easy is what Paul's been talking about for years when it comes to TAVR. So then I think we're going to have a real challenge.
Quick, easy, and good.
Of course.
Okay.
They all
I'll
are
make
good.
sure.
They're all good.
We're a little past time, so I'll go ahead and end the session now, but it was a great start to the afternoon, and we'll be back here at 3:30. Thanks, everyone.